actually have to answer a question to get some action points to move and to attack in the game. So, so did you say, Maimuna, do you want to answer a question with us?
Okay.
All right. So if you would read this guy, we'll try this one.
In the coronary scale phenomenon, vessel dilation is prolongedly harmful because blood is diverted from ischemic areas of the myocardium. Which of the following is responsible for the coronary scale phenomenon?
Right. So are you aware of kind of coronary seal and how it works?
Um, so I am. Should I have to answer it or should I have to explain it?
So either way, I just ask questions to like what you're thinking about. One of the things I wanted to explain is the timer's going, so the amount of time that it takes to answer a question, the confidence with which we answer questions, and the accuracy of the answer will give us a certain number of action points. If we're highly confident and we get it wrong, though, we take some damage. So
I believe that coronary scale phenomenon is where the blood supply to heart is stopped or it's is restricted. The heart supply to the blood.
yeah. So you have the coronary arteries which fill the heart muscle during diastole, and so coronary steal kind of has to do with if you have a blood vessel that is already optimally dilated, then when you take a drug that's going to try to dilate other vessels, what you're doing to that blood vessel that's not receiving enough blood is you're diverting blood away from it by reducing resistance. Because the low resistance vessels get more blood, by dilating the other vessels, you're saying, why don't we send less blood to the coronary artery that's receiving too little blood to begin with?
Yeah. So
that's the nature of all like artery steal phenomenons. So there's also vertebral, there's coronary steal is another phenomenon that happens with your vertebral blood supply to your brain. So this is a physiological thing that happens in a lot of different areas of the body. So what are we thinking about here?
So is it microvasal dilation? I am guessing it.
So it could be. I was so how do you want to? I'll kind of reveal my thinking after we choose an answer choice, but let's rule some answer choices out.
Okay.
What are you thinking it wouldn't be?
It wouldn't be arterial. It wouldn't be larger vessels like arterial or renal dilation.
Yeah, I mean, arterial. Just referring to, I think the kind of. So we'll rule that out for now. So yeah. What about what do you think of in terms of microvessels?
Yeah, I think the microvessels, like they are more they are more towards the heart supply. So or maybe large. Okay, maybe microvessel or large coronary. So I'm between these two, C or D.
So one thing to think about is when they say microvessel, they're talking about like when you have a histamine response. Histamine causes the microvasculature to dilate, and that allows edema to pour out of the microvasculature because the effacement of the smooth muscle contracts, and then the effacement of those kind of areas in the microvasculature allows parts of the blood to flow out of the vessel. And so when we're talking about microvasculature, we're talking about really small. We're talking about the smallest vessels, like capillaries.
Okay.
And so the coronary arteries are way bigger than the microvasculature. So that's one of the things to think about is this is like a histamine response.
Okay.
And so that has, when you say inflammation, That's what you're talking about. You're talking about dilating the microvessels,
Yeah.
usually.
Mm-hmm.
Inflammation refers specifically to the stuff that's coming out of the microvessels when they're dilated. And so, um, do we still like that?
So maybe, yeah, I mean, no, I think dilation of large coronary arteries.
Yeah. So large coronary arteries. Yeah. And then, what about this one? Do you like E?
No, no.
Loss in the fluid in the periphery. Yeah, I don't like that one either. So, what about B?
So venodilation, I mean, if you see between B and D, it's more close towards coronary arteries. So I think I would, I would go for D.
D. Yeah. So I'm not sure what they're gonna say. I like A as well, but we'll see. So, what confidence are you thinking?
Confidence,
Red's like no confidence, and green's like pretty confident.
yeah, pretty confident.
All right, let's do it. Okay, so I talked you out of the right answer. I'm sorry. So the answer is microvessel is responsible for coronary steal phenomenon, acute setting. So ischemic vessels are often maximally dilated, and dilation of coronary microvessels to non-ischemic tissues can cause acute setting divert blood flow. So that's like we just said. So dipyridamole is classically associated with the coronary steal phenomenon. I think you also see coronary steal phenomenon if you take like Viagra in a man with an MI, because Viagra works by dilating blood vessels. And so I think that's one of the reasons you don't want to give Viagra to someone who has a recent myocardial infarction. Sorry about that. I got that one wrong as well. So I think you might have been on the right track with microvessel dilation. So perfused microvessels. So microvasculature and microvessels is different, I guess, maybe. So we don't have any action points yet. Dr. Azithra, I think we'll go to you.
Okay.
All right, so you can read this one, or if you want, or I can read it. Either way.
Okay, so a 9-year-old boy is brought to the emergency department by his mother. He says that he started having a cold yesterday with cough and runny nose. This morning, he was complaining of discomfort with urination. His mother became extremely concerned. He passed bright red urine in an apparent blood clot. The boy is otherwise healthy. Which of the following is most likely underlying cause?
Right.
So it's a very short history.
Yeah. So what are you? I like to rule in and rule out answer choices. So like, what do you dislike about these? Maybe. First of all, what do you think? How would you describe what's going on?
Well, if this is like a patient who just started having a upper respiratory tract infection.
Right.
Started with upper respiratory tract infection and has a UTI, urinary tract infection.
Yeah, well. Discomfort and urination, right?
So I don't understand why he's having hematuria.
Yeah. So there are things. So this is the sort of question where it's perfect because with limited information, you're going to have to answer like experimental questions, all sorts of questions where you don't know the answer, and you have to use test taking strategies to narrow in on what the best guess will be, right? And maybe throughout that process, you'll figure out what the answer is. So, what do we know about BK virus? That's the first thing that. What do you know about BK?
What is BK?
So BK is a virus that you would get. I don't know if you use Sketchy Micro, but I highly recommend it. I like it a lot. Um, and they have some drawings where they illustrate that BK and JC virus are viruses that often are opportunistic viruses during immunocompromisation for kidney transplant patients and organ transplant patients. And so this 9-year-old might be immunocompromised, but we don't really know that they're immunocompromised, and so it's possible that uh, BK is causing the bright red urine, because I know you can have urinary hematuria from BK virus. JC virus really is the one that I know that you can get, bright red urine, but it's really a transplant-associated virus.
Just like cytomegalovirus, that's also like
Exactly.
for immunocompromised.
That's why you irradiate blood to get rid of CMV. So you can get CMV otherwise, but usually you're immunocompromised if you get it. So.
But on the question, it's an acute condition, so.
Right.
Something just happened suddenly.
So this is like rhinosinusitis and upper respiratory tract infection with a cough, and then he had discomfort with urination and passed bright red blood. So it doesn't say. Do you ever get an upper respiratory tract infection associated with E. coli?
No, that's more of GI.
Never, right? Yeah. Yeah, exactly. So what about toxin exposure? How do you feel about that one?
It's a possibility. I'm just thinking of B and D is out because you can't have two similar answers in one question.
Yeah, they're kind of similar. The only thing is the bright red urine and BK association, but I think that I think BK could be yeah.
I'm thinking more of adenovirus. Something
Yeah.
with the upper respiratory.
Also, what's the most common cause of rhinosinusitis?
That's also adenovirus.
Adenovirus, right? Rhinovirus is also, and then in terms of bacteria, strep pneumo and Moraxella catarrhalis. So what confidence do we want to say?
Okay, I'll put it as confident, unless otherwise.
All right, let's do green here and see. All right, we got it.
Yes.
Okay, so let's just check. We'll go to the review on the bottom left here and just check the summary because we got it right. We can just really quick. So this is cystitis, referred to acute inflammation of the bladder, and so adenovirus can cause hemorrhagic cystitis. Do you know of a anti-cancer drug that causes hemorrhagic cystitis?
Is it the platinum? I'm not sure.
No, it's the cyclo.
Platinum-based drug. Cyclophosphamide?
Yes, exactly. Yeah. So that's another one. I just wanted to mention it because it's whenever I hear hemorrhagic cystitis, I think about it.
I'm just a little confused about the question. What's the physiology behind upper respiratory tract infection and he develops cystitis?
So he had adenovirus. He contracted adenovirus respiratorily. So he must have inhaled adenovirus from another child. And then his upper tract infection was caused, but he also has the virus in his serum, in his blood. And it probably hematologically traveled to, his bladder because it binds to certain receptors on your vasculature that can implicate the GU system. So, yeah, I think that's what their explanation would be. Let me make sure.
Yeah. Sure, that is the most.
Yeah. Yeah, so you don't want to, toxins is not really a very, so we talked about BK virus and CMV can cause hemorrhagic cystitis in immunocompromised children, so, yeah, so the spider's attacking us a little bit, so I'm gonna use some of our action points. I'm gonna move away from him so that I can attack, because my attacks are almost all, I'm gonna spend some skill points and make sure that we have enough damage here. So this is a skill tree that you would give to your character. This would be multiplayer, so you'd be playing with other players. And then here we have kind of a basic attack. It tells you where you can attack, but I have to assign these to different slots to use the hotkey. So if I use hotkey 1, hotkey 2, so now I click on E1 and I attack with an action point and attack with another. So we kill the spider. So he drops some weapons for us. So now, Maimuna, I think you go again.
Okay.
All right, so let's do it. I see the fever right away here. Do you want to read this one as well?
Yeah. A 22-year-old female is brought to emergency department by her roommate with 1 day history of fever and malaise. She did not feel well after class the previous night and has been in her room since then. She has not been eating or drinking due to severe nausea. Her roommate checked on her 1 hour ago and was alarmed to find a fever of 102. On physical examination, the temperature is 103. Blood pressure is 110/66. Pulse is 110. Respiration 23 per minute. Pulse oximeter is 98% or no air. She refuses to move her neck and has a rash on her trunk.
Right.
Perform a lumbar puncture and CSF analysis is shown below.
Oh, okay, so we have more here.
Okay.
So it's cloudy. We got opening pressure is actually pretty high. White blood cells are found in the CSF. We have glucose levels that are below normal.
Low.
Yeah, protein, and they even tell you have gram-negative diplococci here.
Yeah, there is a bacterial infection as well.
Yeah. So based on the clinical presentation, what would you?
The following must be administered.
Yeah. So what are you thinking?
So this is like a bacterial infection.
Yeah.
Meningococcal.
So what would you diagnose? What would you diagnose if they had meningococcal infection with this, with a headache and a fever and a rash?
It's a I would diagnose as
It's like meningitis.
meningitis. Yeah.
Yeah, I know you know that. I'm just putting it all into a framework so that when we so really high fever. What if this refuses to move her neck?
It's because of neck stiffness.
Yeah. So neck stiffness, you call that meningismus, which is yeah, and so it's like classic if you were to lift your head. Are you there?
Yeah.
Yeah, so the rash on the trunk, is that implicate a certain type of bacteria?
Yes.
What kind of rash do you suspect it might be?
So I think the meningococcal meningitis has a rash, kind of reddish.
Yeah.
I'm not sure.
Yeah, it's like kind of purplish, like they're purplish red. You're right, and then it has like it's like a petechial rash. And so the other time you see petechiae is when you have low platelets. But you get a petechial rash on your trunk is classic for this type of gram-negative diplococci, which is meningitis. And also with a bacterial infection, you get protein is high. You get low glucose is a classic for bacterial. And white blood cells. Opening pressure will be high because bacteria takes up space in your CSF, right?
I'm sorry, what did you say?
So what do you think? What do you think the treatment would be?
I think it will be ceftriaxone. I'm more towards ceftriaxone, yeah.
So why do you think they included rifampin? that's a harder one. That has to do with so anybody who is near someone with a meningococcal meningitis, you do prophylaxis for secondary exposure.
Okay.
So anybody who doesn't have it yet but might get it is given rifampin. And then
Okay.
they included erythromycin because you can get conjunctivitis from the same bacteria. So
Okay.
that's you'd use an ointment that way. So what confidence would you say you have?
Yeah, pretty sure. Or maybe yellow.
All right. Oh, we got the green. You got it. So I can pick up some plate mail here real quick. And so I look in my inventory. I got the plate mail, and I'm just gonna equip this real quick. So we have some armor, and all right. Now we'll move towards this area. So there could be an enemy here. Mean we have a lot of walking to do. But let's. So Doctor, good job, Doctor Maimuna. Doctor Basritha, you ready?
Yeah.
Let's do it. All right. So you can read if you like.
Okay, a 49-year-old woman with schizophrenia presents to your office after a recent medication change. She complains that she fainted when getting up from the couch and feels very sleepy most of the time. She also complains of urinary hesitancy with a bladder ultrasound showing figure A. Which medication did she use and isn't starting?
Right. So
That,
this.
um, that looks like the walls of the bladder are thick, if I'm not mistaken.
Yeah, potentially. Yeah. So so pretty full, maybe. Trying to interpret this correctly, but I don't have a ton to say except that you're right. I think that maybe the walls are a little illuminated here. And so looking at the whole picture, she complains that she fainted getting up from the couch. So very sleepy most of the time. So one of the things that I think step one does a good job of is they give a disease, and they kind of expect you to know what sort of drugs that person would be on with that disease, such that they would have those side effects. So they tell you the disease, they give you the side effects, and they want you to fill in the blank for the thing that would cause the side effects.
They kind of give you the hint of the answer, the sort of number.
Yeah. So, which medication did she recently start, potentially?
What is your first line drug in the US for schizophrenia? For us here in Africa, I think we use chloromazine.
Oh, interesting.
Yeah.
Yeah, so it depends on so schizophrenia usually if they are currently in a psychiatric episode, olanzapine is a very good option, and refractory hallucinations or delusions, we would use clozapine.
So it means probably she was on olanzapine.
It's probable, yeah, because haloperidol has the problem of like having those D2, yeah, those side effects. Chlorpromazine is less commonly used, but I would lean towards olanzapine before I gave.
I do. You see, in Africa, the problem is we don't have like not. It's a limited resources.
Yeah.
Continent. So there are so many drugs we don't use here, which
Yeah.
are being used worldwide. So I wouldn't go with the answer with A. I would go with A.
Okay. What confidence you thinking?
You can put green.
Okay, we can try. I could steer you wrong, just so you know. So. Okay, so oh my God! Not only did I steer you wrong, but so now you both have gotten a question correct that I got wrong. So let's see why it's not olanzapine. Why is it not olanzapine? So olanzapine is an atypical antipsychotic, so that means second generation, right? And it causes, yeah, so dyslipidemia can cause weight gain and dyslipidemia. And so fluphenazine is a high-potency antipsychotic and cause extrapyramidal side effects. Haloperidol has extrapyramidal symptoms as well. Those are all kind of represented by the, what's the mnemonic? It's, you have dystonia, you can have tardive dyskinesia, you can have extrapyramidal symptoms. And clozapine has the agranulocytosis, so you have to monitor them every 2 weeks for FBC to see if their granulocytes are normal. So like polymorphonuclear sites and cells as well. So orthostatic hypotension, positional fainting, sedation, urinary retention. So another thing to keep in mind is that they hinted at orthostatic hypotension to imply that the drug was chlorpromazine.
Oh yeah.
And so I think although you could give olanzapine, the answer is chlorpromazine.
Probably because it had less side effect than the others.
But also because the side effects that she was experiencing
It's sleepy, yeah.
gives you hypotension and sleepiness.
Oh yeah.
Where olanzapine will make you sleepy, but it won't make you give you positional fainting. And so I think that's the point that they're making there with the histamine kind of receptors that it acts on. So sorry about that. But we'll keep going. But that's a good job though.
Getting them wrong.
Yeah. So my
learn.
exactly. Yeah, I'm learning too. So my Muna, are you ready?
Yes.
All right, let's do it. Do you want to read this one? Novel
A researcher is studying the effect of the novel bacterial toxin on kidneys. She finds that the toxin binds to the segment of the nephron that is circled in figure. Okay. The concentration of which of the following substances decreases the most dramatically in this segment?
Right.
So that is the
Yes.
Is the proximal convolution studio.
Exactly. PCT.
Yeah. Okay, so the concentration of which of the following substance decreases here?
So what are we thinking about?
I'm thinking about I'm between okay, the concentration of which of the I'm more towards water or sodium. Water and sodium.
Yeah. So water is one of those. So one of the things to consider when you're thinking about the nephron is that the concentration of osmoles is higher inside, deeper in the nephron, and so when you look at a nephron here, the osmolality of the kidney is much higher down here than it is up here.
Yeah.
And so water is going to want to leave the nephron more down in the loop.
Here, okay.
Yeah. And so that's one way to think about questions like this. So I would think that water might not be it.
Might not be there. Okay. So how about glucose and I'm maybe glucose or sodium but not potassium.
Yeah. So glucose, if you had a high enough concentration of glucose, you might exceed the capacity of your body to reabsorb glucose. So glucose and protein, you can get too much of it and then you wind up just urinating glucose and protein like in diabetes. So I think the threshold's like 300. At 300, concentration 300, glucose overwhelms the reuptake in the PCT. And
Yeah.
so I think you're onto something. I'm not sure which of these answer choices.
Maybe sodium. I think sodium.
All right.
I'm not pretty, but maybe middle milk or whatever.
If it's water, I'll have to like give you guys the game for free or something because I'm getting everything wrong. Um, so what confidence should we choose?
Yellow.
Yellow. All right, let's do it. It's glucose. Okay. All right, it's glucose. So one of the things I was worried about is they said which is affected most dramatically, as opposed to so so they have an explanation here. This is the PCT. They're just saying that the PCT has carbonic anhydrase, acetazolamide renal tubular acidosis would happen there, but they're not talking about the osmols that would be um, specifically absorbed there. So you're welcome to take a picture of that, but I don't think that's particularly useful. This is how it's saying the mannitol isosorbide. So osmotic diuresis happens here at the loop of Henle. And so descending loop is going to have a huge water transport, absorption. So let's read about this. So glucose, amino acids, bicarbonate, and phosphate in the proximal convoluted tubule. So each segment of the nephron is specialized for differential processing of metabolites, electrolytes, and proximal convoluted such as glucose that are not excreted in the urine. So descending loop of Henle is located for isolated water absorption, which is important for. So we got that right. And then for resorption of sodium, potassium, and chloride, the thick ascending limb. So I think one of the reasons that they wrote this question was to talk about the importance of like loop diuretics.
Yeah.
So like if you took something like furosemide or furosemide, depending on how they pronounce it where you are, it has an enormous effect on blood pressure because you're not peeing the sodium and the potassium and the chloride out. You're retaining it because the antidiuretic, and so you are effectively because of the loop diuretic, you're retaining it in the urine, and so you're not reabsorbing it. And so if you're not reabsorbing it, you're getting rid of it, and sodium controls your blood pressure by retaining water in your vasculature, because water goes where the sodium goes.
Yes.
And so I think the point is that at the PCT, sodium and protein are the most dramatically affected, but in the ascending limb of the loop of Henle is where you'll see your electrolytes and chloride and things affected the most. And so Bartter syndrome and loop diuretics are highly affect those electrolytes. So that's a good one. So Dr. Basritha, are you ready?
Yes, I'm ready.
All right, let's do it.
Okay, so a 33-year-old man is brought by an ambulance to the emergency room after being a passenger in a motor vehicle accident. An empty bottle of whiskey was found in his front seat, and the patient admits to having been drinking the whole night. He has multiple lacerations and bruising on his face and scalp, and the supportive cervical collar is placed. He is endorsing a significant headache and starts vomiting in the emergency room. His vitals, however, are stable, and he's transported to the CT scanner. While there, he states that he does not want to have a CT scan and asks to be released. What is the most appropriate course of action?
Right. So what are you thinking?
So this is a guy who is an RTA victim, and he seems like someone who has brain injury, traumatic brain injury.
Right, potentially. Yeah.
And the patient and the patient is completely drunk, so he is not like giving us the consent to do further management.
Right. So what is what are the criteria that you would need in order to um, consent to a procedure?
Well, if a patient is fully conscious and his GCS is like 15 over 15 and if he refuses, then we don't go ahead and do anything. But if the patient is not in his conscious level, like for this patient, we actually consent in behalf of them or we get a court order to continue treating the patient.
So we'll talk what you said is true. I think one of the words that you would think about for this question is like, is the patient competent?
Which is not.
Which he's not, right?
Yeah.
And so the criteria for competence, you need to know the criteria for competence, and then you need to know, what are the requirements to to consent. So you need competence. You also need to have be explained the procedure, understand what the risks and the benefits are. So there's criteria there that they're getting at. So this is like a medical ethics question.
Yeah. So I would explain to the patient still and explain to him that he's not in the state of making any decisions. I would go for D.
D.
Yeah.
All right, and
because
so
he's not someone you can send home.
Right.
And he's not someone that you want him to like go against the medical advice because probably by the time he regains conscious, he might want to sue us for not attending to him, you know.
Absolutely, and he might not even get a chance because he's gonna die. So it's
because it's a traumatic brain.
right. So if you call security, you'd call security in the event that he was attacking you.
Yeah. He's not. He's just not allowing us to do our job basically.
Right.
But he's not giving us a problem.
So if you tell him that he cannot make healthcare decisions, and he refuses, then I think you could call security.
Yeah.
But he hasn't done anything yet that would suggest that we need to do that. So how confident are we?
Green.
All right, green. I would agree. Yeah.
Yes.
Yeah. That one we're pretty happy with. All right, good. We found the next spider here. So I'm gonna shoot him with an arrow. Okay. So Maimuna, that's we'll try to get 2 in a row here.
Okay.
All right, let's do it.
My 6-month-old boy is referred to a geneticist because of failure to thrive in development delay. He was born at home and had gained establishment of care and feelings of age. At that time, he was found to have restricted joint motion as well as weight in the bottom and percentile. Since then, he has continued to have decreased growth and was found on physical exam to have hepatosplenomegaly. Lab tests reveal high levels of hydrolysis in the blood. The enzyme that is most likely defective in this patient is in which of the following classes? Okay.
So it's really asking classes. All right.
Okay. So he's having hepatosplenomegaly.
Right.
High levels of hydrolysis in the blood. Enzyme is most likely defective in this patient. So it is asking hydrolysis belongs to which of the following classes?
Right. So one of the things you might consider is what kind of disorders are these?
Okay.
You what?
So,
Are these lipid storage disorders or glycogen storage disorders?
you're asking about the options or about the question?
I'm doing the trick of you look at the answer choices and you say what category do all of these answer choices fall into?
So yeah, so I think sphingomyelinates and glucocerebrosidase, they're all lipid
Yeah,
metabolic. Yeah.
exactly. So now you know if we do anything for this question, we should identify which lipid storage disorder is implicated.
Yes.
You know, so that's a good way to characterize what's going on. So what do we know about? Do we know any of these lipid storage disorders? Which ones they refer to?
No idea about this.
That's okay. That's okay. So sphingomyelinase. Does anybody here know what sphingomyelinase refers to?
No.
That's okay. That's okay. So this is one of those things that I think when you're coming from another country, and you're studying for the USMLE. I was an IMG. I was an international medical graduate, by the way. So I think when you come from another country, you think, why would I study all the lipid storage disorders? They're extremely rare, and nobody gets them. But they love these questions. These questions are extremely high yield. They ask these questions all the time on the actual exam. And so these, you want to know the pathway. You want to know the best way to study these is to know this stuff, these words. So sphingomyelinase refers to lipid storage disorders. It's the thing that builds up between two disorders. There's Tay-Sachs disorder, which is a genetic disorder that causes you to have a cherry red spot on your fundoscopy. And you actually, I believe, with Tay-Sachs, you will have hepatosplenomegaly. Whereas that is compared with I'm spacing on the actual name of the disorder. So it's Tay-Sachs is always compared to, I'm just looking up the name here so we can continue on. Niemann-Pick disease.
Niemann-Pick disease, okay.
Exactly. And so Niemann-Pick, this is a different game. So Niemann-Pick or Tay-Sachs is really the question. And so with Niemann-Pick, you'll have sphingomyelinase as your byproduct. With Tay-Sachs, you'll have hexosaminidase.
Mm-hmm.
So these other ones, glucocerebroside, phosphotransferase is a little different. Sulfatase is another a lipid. So those are things to consider. So these pathologies, these syndromes, and their product, what will build up if you have them, are extremely high yield. So I took step 2. I'm not on the step 1 pathway right now, so this is a very detailed question for me. But this is definitely something to really iron out, and we'll talk about it. So let's just choose an answer choice, and then we'll talk about it a little bit.
Okay.
So what are we thinking?
So hydrolysis. So hydrolysis is basically a breaking enzyme. I think we'll go for phosphotransferase.
Phosphotransferase, yeah. So this could be a lipid storage. This could be a hydrolysis. It almost makes me want to say that it might be a glycogen storage disorder. But so what confidence we want to say?
Yellow.
Yellow. Let's do it. Okay. Okay, we got it right, actually.
Okay.
Okay.
Yeah.
So we had hepatosplenomegaly, hydrolases. So this is eye cell disease. So it's acetylglucosamine phosphotransferase present in phosphorylation of 6-position mannose. So this is one of the lysosomal enzymes. So I actually really liked for these. I did Picmonic, which is a website that does this really well for the lysosomal storage disorders. They teach them really well.
Okay.
But Picmonic, so eye cell disease causes failure of lysosomal enzyme to be tagged in the mannose 6 phosphate. So I would memorize that. You can memorize the whole pathway for lysosomal enzymes, and you can memorize the whole pathway for the glycogen storage, and it wouldn't be wasted time. It wouldn't be a terrible use of your time. But I think iCell is a very very detailed question to ask someone to identify eye cell disease. The only thing you want to know about eye cell disease is that phosphotransferase corresponds to the eye cell disease answer choice, and
Okay.
and that you'll have an accumulation of hydrolases. If you knew more than that, you're trying to get a 260, you know. But that stuff, you want to know all of the product really well.
I think hydrolysis and hepatosplenomegaly
Yeah,
first eye cell disease.
yeah,
A lysosomal enzyme.
yeah. I want to say that there was another finding that was very commonly discussed for eye cell disease. I would look at your first aid and maybe identify if there's something in bold concerning eye cell disease. I think there's a pathognomonic detail for eye cell disease outside of the mannose 6 phosphate that you wanted to commit to memory. Psychomotor retardation is definitely something that you see in eye cell disease that sticks out, which is to say that you're slower in your movements. Just talking about hexaminidase being Tay-Sachs and sphingomyelinase being Niemann-Pick. It is Niemann-Pick that has hepatosplenomegaly and Tay-Sachs does not. That is the most important detail. So knowing that Tay-Sachs does not have hepatosplenomegaly and that sphingomyelinase corresponds to Niemann-Pick and that it is hepatosplenomegaly related is a huge deal because they both have a cherry red spot on the macula. So,
Yes.
so they're very similar, except one has hepatosplenomegaly. So I'm gonna have to kick this spider so we can move it away and attack it here. All right, we killed the spider here. So I'll move on to the next round. We got 4 out of 7 for that stage. So now the monsters are gonna get a little harder to kill. All right, so we got a goblin. You what?
How long do we have this class? I'm sorry, how long do we have this class?
Oh, just until 4 o'clock. So I think
We're almost there.
yeah, we might let Sabia try a few questions or maybe one question here. Sabia, do you want to try one? Sabia, are you here?
Hey guys, hey, I'm actually not too well versed with biochemistry questions, so can you just observe for today?
Actually, they're gonna be all over the spectrum. I'll help you out as much as you need, and we'll just have you read it and just learn a little bit. There's no pressure. We've all gotten questions wrong so far. We really,
Okay.
yeah. Just try it out. Just see how you feel. So, try reading this guy out here.
Alright.
So this is so try reading this guy, if you would. Do you want to read out loud, or should I read out loud here?
I can
I'm
say the question in full.
Okay. Yeah, I'm reading the question.
Okay, I'll read it out loud here. So, 18-year-old man comes to the clinic with his mom for pins and needles in both of his arms. So he denies any past medical history beside a recent anterior cruciate ligament tear. repaired 1 week ago. And the patient reports that the paresthesias are mostly located along the posterior forearms. So left more than right. And so what physical examination findings would you expect from this patient? And so there's no need to be nervous if you don't know anything about ACL tears. That's totally fine. So in terms of pins and needles, how do we describe pins and needles?
Hey, I'm really not sure. I'm sorry.
That's okay. I'm just going to ask you questions just so everybody can think about it, and then I'll answer them. So this is like a paresthesia. So that's a neurological description of pins and needles. So one of the tricks that they play on IMGs, you guys are all international medical graduates, I take it. Where are you located, Sabia? If you don't mind my asking. Like.
I'm actually in the, I stay in Dubai. Yes, I graduated from China.
Oh, in Dubai. Oh, okay, from China. Oh, wow. So I've been to Dubai. So I try to warn people that they're going to give you things in UWorld, which everybody should use UWorld. If you don't get through UWorld, you really aren't ready to take the test. So UWorld is very important. But one of the things that UWorld does, and one thing that the test does, is it hurts international medical graduates when they use words that they aren't used to. So you see pins and needles and you think, oh, that's a paresthesia in your own home language, but they're going to use paresthesia on the test. And so there's all sorts of different ways that they will write words so you need to learn a new vocabulary when you're preparing for the exam. That's part of what makes it hard to take the US licensing exam. So it's good to pick these up and really commit them to memory when you see them, write them down and understand them as paresthesias. When you think about pins and needles, just say paresthesia from now on. And so ACL ligament tear, repair 1 week ago, and the patient reports the paresthesias are mostly located along the posterior forearm. So now we have paresthesias in the arm, and we have an anterior cruciate ligament tear in the leg, right?
Yes.
So the question becomes, why do we have pins and needles in both arms? And an ACL tear in the knee. And so I'm still thinking about this question. I think this is actually kind of a difficult question. But what physical examination finding would you expect from this patient? So if it's the posterior forearms that you're having paresthesia, the posterior forearm sensory is provided by your posterior interosseous nerve.
Okay.
And your posterior interosseous nerve comes off of your radial nerve.
Yes, the radial nerve. That's what we're about. Okay.
Right? And so, what else does your radial nerve do? And that's what they're really asking.
Yes. So I think the answer that I'd go for would be loss of wrist extension.
I think that's a great answer. So I hope I didn't lead you astray. I'm just going to mention what some of these other things are. So loss of thumb opposition, that's a loaf muscle. That's the pollicis opponens, so that would be your median nerve. Loss of finger abduction is trying to remember. I think that might also be the median nerve, but I could be wrong. Loss of arm abduction has to do with like C6, C5 kind of brachial plexus. And forearm flexion and supination. So forearm flexion as opposed to extension. So extension is radial. Forearm flexion is median as well, right?
Yes, that's correct.
And so in supination, what innervates the supinator? Do we know?
I'm not sure about that one. I'm sorry.
Okay, no problem, no problem. Does anybody know? Anybody want to try? I think the supinator might be the ulnar nerve, but I could be wrong. Welcome, Mark Thompson. I think we saw you last time as well. So what confidence would you say we have, Sabia?
For this one, I'll go with the green one. Okay.
That's great. You got it. So I'm not surprised you knew you could get some of these. I think you'll be surprised that you know a lot more of these answers than you think you do. So um, Mark Thompson, do you want to try one question before we go?
Before you go ahead, I just wanted to, for supination, it's the radial nerve.
Oh, thank you. Yeah. So let's look at that. That's because I think the arm abduction, it was actually axillary nerve is what they're getting at. So although brachial plexus would affect the axillary nerve, that one's also the axillary. So it innervates the deltoid, which is what affects your abduction of the arm above a certain level. So your supraspinatus helps you abduct the arm, and your deltoid, as well as your it actually turns out your trapezius muscles can actually do this as well. But so radial nerve damage, that was great. I think you answered that for the right reasons. So Mark, are you there? Can we hear you here? Mark, what we're doing is every once in a while we're just asking people to rejoin from the waiting room when their microphone's working. So I'll just do that real quick. Thank you guys for coming this week. I'm sorry, Sabio, we didn't go a little longer to just give you a few more questions. But this week, for the first time in a few meetings, I have to go actually an hour after we start. Usually I'll go like an hour and a half or 2 hours. But you're welcome to stay as long as you want and leave when you like. I hope you guys got something out of it, and love to see everyone next week as well. And if we get enough people coming regularly, we'll even have more than one meeting for step one throughout a given week for a specific group. So I think this is the third time Group C has met. It might be the second time. Rowenda, do you know?
It's the second time.
Second time.
This
Okay.
will be the third.
Yeah.
The
Yeah,
third
mine
one.
is first.
Oh
Okay.
yeah, third, sorry.
Third. Okay.
The
Great.
first one.
And I always mention at the end that we don't get paid for teaching or anything like that. I'm developing a game and I'm promoting it, so you're perfectly welcome to show up. And if you never donated, I would never resent the fact that you never donated. It's just there as an option. You could come to 1 million sessions and never donate. But very much appreciate your time. And I also do one-on-one tutoring for step 1, 2. Anything you could do to promote the game, and go to the YouTube channel, subscribe and like videos. You might even see yourself in some of the videos. So thank you so much, and we'll meet next week.
Thank you so much for your
All right.
time.
Thank you.
We really appreciate it.
Oh, great. Well, I'm glad. That is very nice to hear. All right. Well, I'll see you next week.
Okay.
Bye.